Thank you. Defining success in the treatment of chronic venous insufficiency, something we all want to know about and think we know about. It's just a disclosure that this has been published as the Discord outcome analysis, and much of what I'm going to say is in the European Journal. Now, if we're talking about the disease as chronic venous insufficiency, the task is quite easy because that can be measured. The hardest task is to know what is insufficient. And the minions here can tell us that it is drainage. So drainage insufficiency can be measured fairly easily by the rate of calf filling on dependency and the rate of calf decompression on elevation. And the person that told us all about this was Friedrich Trendelenburg. So nothing too complicated here. And that can all be measured with air plethysmography. But the disease is a little bit more complicated than chronic venous insufficiency. It's chronic venous disease. And that's when it all becomes a little bit tricky. Do outcomes matter? Of course they do. And we're rather obsessed with it. Here we have in this cartoon, brilliant surgery, well done, shame the patient died. But in reality, there are 4 outcomes. You can have brilliant surgery, well done, the patient lived. You can have terrible surgery, the patient lived, terrible surgery, the patient died. And all 4 outcomes are important because it tells us about the process of how we get to the endpoints. This is my favorite slide. It's the aims of treatment. And these have to be established really first before we can move on to what an outcome is. And it's illustrated as a Venn diagram. What is important is, are we treating the lesion, the varicose vein, the telangiectasia, the ulcer, the lipodermatosclerosis? Or are we treating the symptoms of the patient? Or are we actually treating the disease itself, chronic venous insufficiency? And this is illustrated nicely with a Venn diagram. They overlap. And it's the first step towards personalized outcomes. But in reality, our current assessment tools are not simple at all. We go for quality of life, clinical severity, and we look for saphenous occlusion when we start off with reflux. So there is a major discord on what we want to measure, the lesion, symptoms of the insufficiency, to what we actually measure with the assessment tools. There has to be a better way. This is an illustration of what I'm talking about. Patient on the left, no pain, no varicose veins. The one on the right, lots of pain, lots of varicose veins. So if you're going to treat the one on this one over here, you're going to get a great success. If you treat this in a fairly symptomless patient, you're not going to get much success at all. So which one's more severe, this one or this one? Total confusion. And so is the discord of edema assessment. This is true venous edema. It's only one leg is affected, it's much larger, it's congested all the way up to the big toe, and it's warm, it's non-pitting, it's constant, and you get it as soon as you get out of bed. You don't have to wait till the end of the day to get this. We've got lots of objective reference values for other diseases, hypertension, blood pressure, and so on and so forth. But we have also one for venous insufficiency, and it quantifies the insufficiency of the leg quite nicely using the venous filling index of air plethysmography. And these is very easy to interpret. They are just volume versus time charts. Nothing complicated like ultrasound with lots of astral images. And in an obstructed patient, for example, from standing to reclining, it takes half a minute to reach that volume. And then from reclining to Trendelenburg, a minute and a half to go down to that volume. Whereas in a refluxing patient or a patient without obstruction, 2 seconds. And from reclining to Trendelenburg, 4 seconds. So there's no contest. It's very easy to discriminate between reflux and obstruction and to quantify both. And this brings us nicely to the Discord outcome analysis. What is the definition of success? Well, it should be this green tick over there. And that means an improvement in quality of life, an improvement in clinical severity, and an improvement in reflux. But we don't do this for our patients. We hide the truth. This is what happens if you use ultrasound. We had a randomized controlled trial comparing laser with foam, and these are the 5-year ultrasound results. If we take the success as above knee occlusion at some point, we've got a 93% success with laser and a 64% success with foam. Statistically significant. It's an old study, and the results are comparable with other studies. But as we start changing the duplex outcome definitions, our ratios changed and our statistics changed. So we can always do a little bit of reverse engineering. We can get the result we want by changing the criteria of how we assess patients. If we take a very harsh endpoint, for example, no reflux at all, including tributaries, we only had a 27.3% success rate, and there was no difference between the two groups. These are the 3 domains: quality of life, clinical severity, and improvement in the venous filling index. Everything above this dashed line means an improvement. And looking at this, you'll think, well, we haven't done too badly with quality of life, maybe a bit better with venous clinical severity, fairly good with venous filling index. The quartiles are all sort of above this dashed line. So the results, okay. But let's do a Discord outcome analysis. That means an improvement in quality of life, clinical severity, and venous filling index. Our statistics start getting worse. Only 3/4 success with laser, 60% success with foam. Not that good, is it? Now, what about significant success, which is post-treatment minus pre-treatment value? Success is everything above the line, this dashed line, but this long dash is a significant success. So that is above repeatability tolerances and above minimally important different values. A real success for the patients in quality of life, clinical severity, and venous filling index. And we can see that we're starting to encroach on the interquartile ranges. But when we do a Discord outcome analysis, success in all 3 domains, only 50% just with laser, 40% with foam. Appalling results, because we've assessed it correctly. And it's only when we look at these results are we going to improve the quality of the treatment for our patients. This is a Discord outcome analysis on the anterior accessory saphenous vein recurrences from our group at 5 years. So these are all duplex failures because of recurrence in the anterior accessory saphenous vein. And there's parallel reflux in other areas as well. And these are the 3 domains: Aberdeen, venous clinical severity, venous filling index. Now, if we look at this C6 patient that had laser, outstanding success in Aberdeen questionnaire, outstanding success in venous clinical severity score, wonderful result of venous filling index, but on ultrasound we've got refluxing below anterior accessory, refluxing above knee great saphenous and below knee great saphenous vein. So is that a success or is that a failure? There are many causes of a Discord outcome. The quality of life worsens, but the clinical severity improves. Thus, you got the diagnosis wrong. There's pigmentation as a side effect. The opposite, better quality of life, deteriorating venous clinical severity. Maybe that's because the other leg has been treated successfully, or the patient is compliant with stockings. Because don't forget, if you're compliant with stockings, it's a negative point on the venous clinical severity score. And we have an improvement of venous hemodynamics, but a deterioration of quality of life. What's that due to? Perhaps it's inappropriate treatment. You just treat your reflux because you see it, but it's got nothing to do with the condition, the cause of the patient, or the incorrect treatment aims. So it's all about appropriateness. Peter Lawrence talks about it all the time in various societies. It's when good results are not enough. It's not all about treating reflux. It's not all about occlusion rates. So this is the conclusion that the Discord outcome analysis, it provides transparency in randomized controlled trials. It prevents the overinterpretation of success. It identifies appropriateness. Tells us whether we are treating the patients that we should be treating, and it should be recommended as a reporting standard. But more important, it paves the way for personalized outcomes. What is the outcome for that patient? If they have a lesion and they want the lesion treated, the focus should be on the lesion. If it's on symptoms and leg pain, it should be on symptoms and leg pain. And a Discord outcome analysis has been proposed as a way forward in assessing this and paving the way for better outcome measures. Thank you very much.